This conference will now be recorded.
Good morning, everyone. Today, our topic of interest is another important topic, that is peptic ulcer disease. In previous classes, we have discussed alcoholic liver disease, gastroesophageal reflux disease, cirrhosis of liver, and its complications like portal hypertension, hepatic encephalopathy. So all these things we discussed in the same arena. And the next important topic of interest is, that is peptic ulcer disease. This is also an important short notes that is frequently asked in your final examinations. That is part 2. So try to concentrate. So what is peptic ulcer disease? It's nothing but is a condition characterized by erosion of gastric intestinal mucosa resulting from digestive action of hydrochloric acid and pepsin. So these hydrochloric acid and pepsin together, what they involved in this pathology is these damage the gastrointestinal mucosa. So because of this damage, what happens is this mucosal structure or epithelial structure gets eroded and they will be converted into an ulcers. So this condition characterized by erosion of gastrointestinal mucosa resulting from digestive action of hydrochloric acid and pepsin. So it is a inactive form of pepsin is pepsinogen. So the pepsinogen is converted into the pepsin, which ultimately damages the gastrointestinal mucosa. So coming to peptic ulcer disease in per se, that is ulcer development that is mostly in the lower esophagus part, that is stomach, duodenum, and it includes 10% of men. Peptic ulcer disease accounts for 10% of men and 4% of women. So this clearly suggests that this is predominantly more common in men than women. So coming to the types of peptic ulcer disease, there are acute type and chronic type. In acute type, there may be superficial erosion or minimal erosion. Whereas in the chronic type, there is muscular wall erosion with formation of fibrous tissue and present continuously for many months or intermittently. So these are the two types, that is acute and chronic type. So here we can see as the ulcer predominant areas, that is the lower end of the esophagus. Here we can see the stomach region. Here we can see the duodenum part. So these are the ulcers. These are most common here in the lower part of the esophagus, stomach, and the duodenum. So peptic ulcers, that is, as I mentioned, the two types, are the gastric ulcers and duodenal ulcers. So coming to the classification based on the classification, they depend upon the location, that is the stomach. Then it is termed as a gastric ulcer. If the ulcer is in the duodenal part, that is duodenal ulcer, and esophagus called esophageal ulcer. So these types of gastric ulcer again depends according to the modified Johnson's criteria. They are classified into the 5 types. They are type 1, type 2, type 3, type 4, and type 5. So what is type 1? If the ulcer along the lesser curvature of the stomach, then it is type 1. And the two ulcers present, one in gastric and one in duodenal, then it is type 2. And it is when present in the prepyloric region, then it is called as type 3. And when it is proximal gastroesophageal ulcer is then it is called as type 4. And if it is like anywhere other than this part, that is NSAID induced, then it is called as type 5. So remember this, these types of gastric ulcers are classified based on the modified Johnson's criteria. They are type 1, type 2, type 3, type 4, and type 5. So coming to the first part, that is the gastric ulcers, and they are commonly found on lesser curvature in close proximity to the antral junction. So less common. So these gastric ulcers they are less common than the duodenal ulcers and prevalent in women, older adults, persons from lower socioeconomic class. So when compared to as initially in the first slides we have discussed that these ulcers are most predominantly in men than women. But here you can see that gastric ulcers are predominantly that prevalent in women and older adults than persons are than men. So these gastric ulcers are characterized by a normal to low secretion of gastric acid. Bad diffusion of acid is greater, that is in case of the chronic ulcer type. And critical pathologic process is amount of acid able to penetrate mucosal barrier, that is H. pylori is present in 50 to 70% of these ulcers. So this incorporation of this H. pylori, Helicobacter pylori, which acts as a major crucial important role, that is in the pathogenesis of these ulcers. So H. pylori is thought to be the more destructive when noxious agents are used or patient smokes. So coming to the drugs can cause acute gastric ulcers. Like the drugs that can cause these acute gastric ulcers are aspirin, corticosteroids, NSAIDs, and reserpine. So remember this, among this all these things, you have to remember aspirin and NSAIDs. So that is why we if you suppose if a patient on stroke patient, then before starting an antiplatelets, we will be asking the patient whether there is any history of melena or that, because the patient used to abuse all these NSAIDs, then there may be ulcers, and if we give the patient that on antiplatelets, then the person may bleed prolonged. So that is why you have to interrogate the thorough investigations regarding history wise, that is regarding the uses of drugs that are like aspirin, non-steroidal anti-inflammatory drugs, etc. Or known causative factors like chronic abuse, as well as in the previous classes, like in the alcoholic liver disease, I have mentioned that if there is chronic alcoholism, there will be acute gastritis, like chronic gastritis features. So coming to the second part, that is duodenal ulcers. These ulcers can occur at any age and in anyone between the age groups of 35 to 45 years, and this accounts for about 80% of all peptic ulcers. So see here. So these accounts are mostly among these peptic ulcers. These accounts about 80%. So it is associated with increased HCl acid secretion, and H. pylori is found in 90 to 95% of patients, and its direct relationship has not been found. Whereas in gastric ulcers, they have mentioned that there is a direct relationship with the H. pylori. So whereas in duodenal ulcers, there is no direct relationship that has been found. So in these diseases the diseases with increased risk of duodenal ulcers are like chronic obstructive pulmonary disease, cirrhosis of liver, chronic pancreatitis, hyperparathyroidism, chronic renal failure. So all these conditions are lead to the hypercalcemia feature. So because of this hypercalcemia, this calcium is which is toxic to these ulcers may develop. So treatments used for these conditions may promote ulcer development. So coming to the peptic ulcer disease clinical manifestations, this is common to have no pain or other symptoms, and gastric and duodenal mucosa not rich in sensitive pain fibers. So that's why they may not have pain or some other, and duodenal ulcer pain like burning, cramp like, whereas gastric ulcer pain which is like burning and gaseous. So here you can see the appreciate here symptoms, that is differences between the gastric and duodenal, that is an early sense of fullness with eating and frequent burping or hiccuping, and stomach pain wakes up you at night, blood loss in stools, melena, hematemesis, water breast, bloating sensation in the stomach, and frequent burping or hiccuping, and low blood cell count like anemia, vomitings and appetite changes, unexplained weight loss, nausea, burning, sense of pain. These are all the clinical manifestations or some of the symptoms of this peptic ulcer disease. So in the current duodenal ulcer, classical symptoms of a duodenal ulcer include burning, gnawing, aching or hunger-like pain, primarily in the upper middle region of the abdomen, below the breastbone, the epigastric region. So pain may occur or worsen when the stomach is empty. So here see, this pain usually worsen on empty stomach. So usually 2 to 5 hours after a meal. So symptoms may occur at night between 11 and 2 a.m. Why? Because what happens is usually we take food around 7:30 or 8 p.m. So as I mentioned, usually after 2 to 5 hours means if we consume the food at 8 o'clock, then obviously the patient may land into fasting level state from around 10 to 11 or 10 to 1 or around 11 to 2 o'clock. So that's why these patients may have pain during the sleep at the night time. So the patient may have very disturbed sleeps. So these people feel better when they eat or drink, and then worse 1 or 2 after later. That's duodenal ulcer. So in case of gastric ulcer, symptoms of gastric ulcer typically include pain soon after eating. So what happens here, that a major difference between this gastric ulcer and duodenal ulcer, here the patient experiences the pain during the fasting, that is after the consumption of food after for 2 to 5 hours. But here you can see this gastric ulcer patient, soon after the consumption of food, this patient develops pain. So symptoms are sometimes not relieved by eating or taking antacids. So complications, coming to the complications, 3 major complications we have to remember, that is hemorrhage, perforation, gastric outlet obstruction. These are the 3 important major complications of peptic ulcer disease. So initially these complications are treated conservatively, and yet in some people these conditions may require some surgical intervention at any time during the course of therapy. So if the patient is refractory to the medical therapy, or he may not relieve his symptoms or not relieve, then we ultimately we have to go for the surgical correction. So in that condition, these patients may require surgery. So how will you diagnose these peptic ulcer diseases? With the endoscopic procedure most commonly used, and which determines the degree of ulcer healing after treatment, and tissue specimens can be obtained to identify the H. pylori. As I earlier discussed, mentioned that in gastric ulcers and duodenal ulcers, the gastric ulcer may have direct relationship with this H. pylori infection, and also to rule out the gastric cancer. So coming to the diagnostic studies, for the first for the test for the testing the Helicobacter pylori infection, there are two types of tests. There are non-invasive tests and invasive tests. And coming to the non-invasive test, these are serum or whole blood antibody test, immunoglobulin IgG, or urea breath test. These are the two non-invasive tests. When coming to the invasive test, that is biopsy of the stomach and rapid urea test. These are the two invasive tests. So just remember these types of tests for diagnosing the H. pylori infections. They are can you remember? They are non-invasive tests and invasive tests. And examples of non-invasive tests are serum or whole blood antibody test, or or IgG immunoglobulin, urea breath test, or invasive. Coming to the invasive test, that is biopsy of stomach or rapid urea test. So other diagnostic studies are barium contrast studies are widely used, and X-ray studies. It's ineffective in differentiating a peptic ulcer from a malignant tumor. So coming gastric analysis, this analysis in identifying a possible gastrinoma or any determining degree of gastric hyperacidity and evaluating the results of therapy. So these are some of the diagnostic studies that are helpful in peptic ulcer disease. So coming to the laboratory investigations like complete blood counts, urine analysis, liver enzyme studies, serum amylase determination, stool examinations to rule out any parasitic infections like amoebiasis. So like that, we have to rule out the other conditions like other parasitic manifestation. So what is the aim of the treatment means? So first initially we have to promote for the ulcer healing. Then we have to make sure that the patient get relieved from pain, and we have to prevent the relapse. That is, reoccurrence of these symptoms should be targeted and they should be prevented. And the next one is the prevention of complications. So coming to the drug treatment of peptic ulcer, is the first is gastric hyposecretory drugs like H2 receptor blockers, muscarinic receptor blockers, proton pump inhibitors. So these three groups of drugs, previously I have mentioned GERD also, they are the first line drugs. That is, the proton pump inhibitors are the first line drugs when compared to the H2 receptor blockers. So similarly, here also the gastric hyposecretory drugs like H2 receptor blockers, muscarinic receptor blockers, proton pump inhibitors, and second group of drugs in eradication of H. pylori infections and also to prevent its relapse. And third subgroup of drugs like mucosal cytoprotective drugs like sucralfate, colloidal bismuth, prostaglandin analogs, and other fourth group of drugs are the neutralizing agents like antacids. So coming to the first group of drugs that are high gastric hyposecretory drugs, as mentioned, that H2 receptor blockers, proton pump inhibitors, and muscarinic receptor blockers. These by decreasing the gastric acidity, these decreases the reduce absorption of ketoconazole and iron preparation digoxin. These are also affecting this absorption. So coming to the proton pump inhibitors, this mechanism of action is, it is irreversible inhibition of proton pump, that is potassium or hydrogen ATPase, that is responsible for final step in gastric acid secretion from the parietal cell. So these some of the examples of proton pump inhibitors, these include omeprazole, lansoprazole, pantoprazole, and esomeprazole. So you will be very well versed with this pantoprazole, as we will be very frequently prescribed in these drugs too. So among the major section of the people. So major section of the people will coming to the OPD, they will be complaining of, sir, we are having burning sensation in the stomach, and some people may like present like the abdominal tightness, and some people may present like dyspepsia, and some people may say, sir, they have burning sensation in the throat. So for all these patients, generally we will be prescribing this proton pump inhibitors, as I mentioned that in gastric esophageal reflux disease, the most commonly used drugs that are proton pump inhibitors, then followed by the historeceptor blockers. So here we can see the gastric secretion by pan-external cells. So coming to the pharmacokinetics of these drugs, they are products they are generally taken orally. So it means the product means they'll be converted into the active form after they enter the intestine. So these are given as entry coated capsules, and they are rapidly absorbed from the intestine. They are activated in the acidic medium of the secretory parietal cells canalically. See, this is what I want to say, that here these are proactive. These are not active drugs. Before this active form is produced, these are formatted in the form of prodrugs. So soon after they enter the acidic medium within the stomach cell, that are parietal cells, these will get activated. So they are inactivated if combined with historeceptor blockers. So these should not be combined. So proton pump inhibitors and H2 blockers should not be combined. So these have long duration of action, that is greater than 12 hours and lasting for about 24 hours. So these are generally prescribed as once daily dose is sufficient. So that's why we are prescribing the patient that usually ask the patient to take it empty stomach. That is as soon as they woke up, then we will ask the patient to take it on empty stomach, so that it will have a duration of about 12 hours and lasting for about 24 hours. So bioavailability is reduced by food, so that's why we have to ask the patient to take it on empty stomach. So given 1 hour before meal and are metabolized in the liver by cytochrome P450 enzyme, and they are more potent than historeceptor blocker, as I mentioned previously. That is proton pump inhibitors are more preferable or first line drugs than when compared to the historeceptor blockers, and these inhibit the basal and stimulated acid secretion, and dose reduction is required in severe liver failure. So why the dose reduction is required in severe liver failure? Because as these are metabolized by cytochrome P450, which are present within the liver. So that is why in case of any liver diseases, these reactions are altered, so that gets accumulated. So that is why the dose should be given in a controlled manner, or should be, or also it may be reduced, so that prevent any adverse effects on the liver, for adverse effects on the liver cell, which is further getting damaged. So coming to the uses, these other uses of this proton pump inhibitor, Zollinger-Ellison syndrome, that is first child, and resistant severe peptic ulcer for 4 to 8 weeks, and reflux esophagitis and eradication of H. pylori infection. So coming to the adverse effects, GID disturbances like nausea, vomiting, diarrhea, echlorhydria, hypergastrinemia, gastric hyperplasia, increased bacterial flora, that is nitrosamine. So these are the some of the adverse effects, and you can see the uses. All these are the regarding the proton pump inhibitors. Then now coming to the second group of drugs, that is H2 blockers. So what is the mechanism of action? They competitively and reversibly block to the H2 receptors on the parietal cells, thus reduce gastric secretion, and they include cimetidine, ranitidine, famotidine, and nizatidine. So coming to the pharmacokinetics part, that it has good oral absorption, and plasma half-life is about 1 to 3 hours, and duration is 4 to 12 hours. So it's a twice daily dose. So first pass metabolism 50% except nizatidine, 100% bioavailability. It has 100% bioavailability, and this should be given before meals, and it's generally metabolized by liver and excreted mainly in urine, and cross placenta and excreted in the milk. So I have given this, see here a very simple manner I have prepared, so that you can able to see the slides and remember some of these points. You may not remember all these points, but the main motto of this, why I have segregated in previous compared to previous classes, this class I have given only single lines, so that if you see some of the points you may remember. So that's enough. So remember some of these points, not all the entire points you may not remember. So can you remember some of the points that half-life is about 1 to 3 hours and duration is 4 to 12 hours. If you see like this, then you will be remembered. So that's why I have make it in a cut short manner, so that you can remember easily. So regarding the drug efficacy between the 4 drugs that are same group, that is cimetidine, ranitidine, famotidine, nizatidine. So here you can see when efficacy is taken into as a factor, then you can see all the 3 and 4 drugs have same efficacy. When compared to the potency, this famotidine has more potent when compared to other 3 drugs. So you can see this dosing daily. Cimetidine, that is 400 milligrams BID dose, and ranitidine, that is twice daily, that is 150 milligrams. and famotidine, that is 20 milligrams BD dose, and nizatidine, that is 250 milligrams BD dose. So both all these 4 drugs are can be given orally except nizatidine, which is cannot be given IV. So remaining 3 drugs can be given or IV also. So you can see this half-life when compared to all this, the so long for ranitidine and famotidine, and shortest is for nizatidine. So coming to the duration of action, you can see here famotidine having 12 hours duration and followed by ranitidine. So that is why we generally prefer ranitidine as a H2 blocker. So that's why we are giving the patient as twice dosing. So coming to continuation of pharmacological actions, see, inhibit histamine, gastrin, cholinergic drug, and induced secretions, and reduce basal and food stimulated gastric secretion, and reduce pepsin activity, promote mucosal healing, and decrease pain. So coming to the uses, these H2 receptor blockers are used in treating the duodenal ulcers, benign gastric ulcers, reflux esophagitis, Zollinger-Ellison syndrome, pre-anesthetic medication, and eradication of H. pylori infection. These are all the uses of H2 receptor blockers. So when coming to the adverse effects, so we can see that these adverse effects like involving the gastrointestinal system, central nervous system, and CVS. When coming to the gastrointestinal GIT disturbances, nausea and vomiting are common for any drugs. These two may be common features like having like nausea, vomiting, and coming to the CNS effects like headache, dizziness, confusion, and coming to CVS effects like bradycardia and hypertension. These are some of the adverse effects of H2 receptor blockers. And similarly, and other adverse effects, endocrine effects like anti-androgenic actions, galacturia in women, and cytochrome P450 inhibitor decrease metabolism of oral anticoagulant, phenytoins, and benzodiazepines. So precautions that should be taken in when using this H2 receptor blockers are maintenance dose, dose reduction in severe renal or hepatic failure in elderly. As I mentioned that in case if we are not reducing the dose in case of the renal and liver disease, there may be some other aggravating this liver pathology or any renal conditions gets aggravated if you won't reduce the dose. So next coming to the anticholinergic drugs, that is muscarinic, that is the non-selective muscarinic blockers like oxyphenonium, dicyclomine, and these decrease the gastric acidic motility and delayed gastric emptying, heartburn, atropine-like side effects. Coming to the selective muscarinic blockers like pyranzapine, telanzapine, and these block M1 receptors on the parietal cells, selectively inhibit gastric acid secretion, and no effect on gastric motility, less side effects on cholinergic blockade, no effect on central nervous system. So dose is generally 50 milligram BID for 4 to 6 weeks. So in this slide you have to remember that. Just remember that selective muscarinic blockers are pyranzapine and telanzapine. So what is the mechanism of action? These blocks the M1 receptors. So what is the dosage? 50 milligrams. So if you remember the dose or that's not important. Just remember the drugs that selective muscarinic blockers as pyranzapine and telanzapine, and mechanism of action is blocks M1 receptors. So these are adjuvants to H2 receptor blockers and decrease nocturnal pain in peptic ulcer. So coming to one of the important thing that is H. pylori, as I mentioned as a previous slide, it is a major role in this gastric acid ulcer formation. So how will we eradicating this H. pylori? So it is a bacteria that causes chronic inflammation of the inner lining of the stomach, and it produces the enzymes that damages the tissue and forms inflammation and resulting in ulcers. So duodenal ulcer, gastric ulcer, and risk factor for esophagus and stomach cancers. And to prevent the recurrence of ulcer, so this should be eradicated. So here you can see the H. pylori association with gastric mucosa. So treatment. So how will we treat this for eradicating this H. pylori infection? Means it will be having a combined therapy by using of different types of antibiotics like clarithromycin, tetracycline, amoxicillin, and with the combination of proton pump inhibitors or H2 receptor blockers, and with the combination of bismuth compounds, metronidazole, and resistance. Sometimes in some people, because of this uses of this antibiotic, some people may develop resistance. So better eradication is obtained using proton pump inhibitors and clarithromycin. So among all these drugs, proton pump inhibitors and with combination of clarithromycin is generally used for this eradication of H. pylori. So treatment part, the standard first line therapy is called triple therapy, consisting of, so in this triple therapy, so it should include 3 groups of drugs, that are proton pump inhibitors as omeprazole, antibiotics like clarithromycin and amoxicillin. So these are is called triple therapy. So here see the regimen. So this is very important regimen. You have to remember, that is bismuth metronidazole and tetracycline. You can see one group, that is omeprazole, metronidazole, clarithromycin, one group of drugs regimen, and omeprazole, amoxicillin, and clarithromycin, again another group of drugs, and omeprazole, bismuth, metronidazole, amoxicillin, tetracycline. No need to remember, just remember that regimen. So what regimen? So triple therapy. So you used it. Just remember, triple therapy is used in eradicating H. pylori infection. So coming to the another subgroup of drugs that are used for the treatment are mucosal protective drugs, that are sucralfate, prostaglandin analogs, and colloidal bismuth. So these sucralfate, what is exactly is sucrose octaphosphate and with combination of aluminum hydroxide. So what is its mechanism of action? In acidic pH, sucralfate dissociates into its components, and the negatively charged sucrose octaphosphate binds with positively charged protein molecules found in damaged mucosa, put over the ulcer, that is promote ulcer healing and inhibition of pepsin. So in this way, this sucralfate helps in healing this process. So see, okay, once you can see this, the mechanism is very important. So in acidic pH, what happens is this sucralfate dissociates into its components. So the negatively charged sucrose octaphosphates bind with the positively charged protein molecules found in the damaged mucosa. So what happens if this negatively charged octaphosphate, sucrose octaphosphate, with interacts with this damaged part, and it acts as a coated. So what happens is when it combines, it forms like a coat over this ulcer. So that's why the patient may not feel the sensation of pain. So it helps in also the promoting the ulcer healing, inhibition of pepsin. So stimulation of protective mechanisms, mucosal bicarbonate secretion. Coming to the pharmacokinetics of this sucralfate, oral, poorly systemic absorption, duration 6 hours, excreted in feces. Avoid co-administration of antacids or H2 blocker. Better taken on empty stomach. So therapeutic uses: benign gastric and duodenal ulcer, chronic gastritis, and adverse effects like constipation and dry mouth. Interferes with absorption of some other drugs like tetracycline, theophylline, tricyclic antidepressants. So another next one is the prostaglandin analogs like misoprostol. That is, I mentioned that prostaglandin analog PGE1, HCl secretion, promote tight junction of gastric cells, prevent back diffusion of HCl, mucus and bicarbonate secretion, blood flow of mucosa, improves healing of ulcer, and orally 30 minutes it is converted into active metabolites, and finally it is excreted in urine, so that it must be taken 3 to 4 times per day. So coming to its therapeutic uses, that prostaglandin analogs, that prevention of NSAIDs induced peptic ulcers. So misoprostol, that is used in preventing the prevention of NSAIDs induced peptic ulcer. And coming to the adverse effects like abdominal cramps, diarrhea, uterine contraction, dysmenorrhea, abortion, and vaginal bleeding. And coming to the colloidal bismuth compounds like bismuth subcitrate, tripotassium dicitrate or bismutate, and mechanism of action is it forms a precipitate with mucus cover the ulcer with a protective coat that prevent the effect of HCl. So what its exact mechanism means this colloidal bismuth compounds, what is similar to that of previously, as I said, that it forms a coat over the. So similarly, this also prevent a coat, so that when excess HCl is produced also, so as a layer of coating is formed, so that this action of HCl on that particular part of GI mucosa is inhibited, so that there will be no damage, and this also promote the healing of ulcer and bactericidal effects against like Campylobacter pylori, and decrease as activity of pepsin and mucus and bicarbonate secretion. So coming to the adverse effects like black stool, some of the adverse effects of the bismuth compounds are black stools, teeth discoloration, encephalopathy in renal dysfunction, and uses are like, as I mentioned in the previous, eradication of H. pylori, that is used in the triple regimen, that is triple therapy for eradication of H. pylori, benign gastric and duodenal ulcers, that is, and also used in traveler's diarrhea. So the drugs that neutralize HCl, that is antacids, drugs used to relieve gastric pain associated with hypersecretion of HCl. So what is the mechanism of this antacids? They are plays a role in neutralization of the hydrochloric acid, inhibition of the pepsin, that is inactive at pH 5, and the coming to the therapeutic uses of this antacids, relieve pain of peptic ulcer and also prevents dyspepsia. So coming to the systemic antacids, what are the systemic antacids that we should know? That are sodium bicarbonate. So sodium bicarbonate, coming to its disadvantages, it will have rebound hyperacidity, stomach distension due to carbon dioxide liberation, sodium load, salt and water retention, systemic alkalosis. So these are the some of the side effects or disadvantage of systemic antacids. So coming to the next one is the calcium carbonate and some of these disadvantages are, so what happens mechanism of action, see previously what happens is sodium bicarbonate, this react with the hydrochloric acid, so the liberate sodium, so form the sodium chloride and the carbon monoxide. So in this way this HCl is utilized. So here also similarly you can say this calcium carbonate combines with the hydrochloric acid to form calcium chloride, water and carbon dioxide. So in this way this excess hydrochloric acid is removed. So these are some of the disadvantage of this calcium carbonate are liberation of carbon dioxide like stuff. So as a result there will be gastric distension and 10% is absorbed, so resulting in hypercalcemia and rebound hyperacidity and milk alkali syndrome like hypercalcemia and resulting in renal failure. So these are the systemic antacids like calcium chloride and sodium bicarbonate. Coming to the non-systemic antacids, they are aluminum hydroxide gel, magnesium trisilicate. So here see how exactly the mechanism of action is here. This aluminum hydroxide combines with the hydrochloric acid, so they're liberating the HCl3 and water. So what are the advantages of this non-systemic antacids are, it has a longer duration of action and gradual neutralization of hydrochloric acid, that is no rebound hyperacidity, and absorbs pepsin and minimal change in acid base balance and no stomach distension. So coming to the disadvantage of this aluminum hydroxide, it produces constipation, drug interaction, and decreases the absorption of tetracycline, digoxin, and iron. And when coming to the magnesium trisilicate, the exact side effects of this are diarrhea, central nervous system depression, and also renal failure also. So some other antacids like alginates, gavics, and combined with antacids in reflux esophagitis to increase adherence of mucosa to esophageal mucosa. So thank you. So just remember, if the peptic ulcer disease question is asked, so you have to write the definition. That is the condition characterized by erosion of gastric mucosa resulting from digestive action of HCl and pepsin. So development of the ulcer, so on which part these are most common. Then again you have to classify them as types. You have to write regarding the types of ulcer and the peptic ulcers that are acute and chronic. And then coming to the acute, superficial erosion and minimal erosion, and chronic muscular wall erosion with formation of fibrous tissue and present continuously for many months and intermittent. So you have to write regarding the types. Then you have to categorize that gastric and duodenal ulcers. So you have to write regarding the gastric ulcers based on the modified Johnson's criteria. They are classified into 5 types: type 1, type 2, type 3, type 5. And again you have to write the differences between the gastric ulcers and the duodenal ulcer, that is pain aggravated in the fasting as in case of duodenal and relieved on after taking food. The differences should be mentioned. So again the clinical manifestation should be mentioned, like here we can see the grossly this slide: an early sense of fullness with eating, stomach pain wakes up you at night, blood in the stools, melena, hematemesis, water brush, bloating, frequent burping or hiccuping, low blood count, anemia, vomiting, appetite changes, unexplained weight loss, nausea, burning pain, etc. So these are all the things should be mentioned, and the complications as I mentioned. Then you have to write regarding the after the clinical manifestations. You have to write. You have to remember the clinical complications, like 3 major complications like hemorrhage, perforation, gastric outlet obstruction, and diagnostic studies. As I mentioned, that endoscopy should be endoscopy procedures should be most commonly used, and also the tissue regimens like for regarding the identifying the H. pylori infection. So for I mentioned, for identifying this H. pylori infection, again there will I mentioned that 2 tests, that is invasive test and non-invasive test. So non-invasive tests like whole blood antibody test, or invasive test like biopsy of stomach and rapid urease. So other tests that should be remembered that are barium contrast studies, X-ray studies like that, and the gastric analysis should be done. So these are all the diagnostic models. So how will we treat means, first we have to promote for healing, for ulcer healing, then symptomatic relief, then preventing the relapse and preventing the complications. So these are the 4 subheadings should be remembered in the aim of treatment. So what is that? Ulcer healing, symptomatic relief from pain, recurrence, and prevention of complications. So again the subgroup of drugs that are gastric hyposecretory drugs, eradication of H. pylori infections, mucosal cytoprotective agents, neutralizing agents. Just remember these 4 subheadings. That is enough. That is gastric hypersecretion, H2 receptor blockers, muscarinic receptor blockers, proton pump inhibitors, and eradication of H. pylori infections like and also the mucosal cytoprotective sucralfate, colloidal bismuth, prostaglandin analogs, and neutralizing antacids. So the antacids are again 2 types that are, as I mentioned, that systemic antacids and non-systemic antacids. And systemic antacids include sodium bicarbonate, calcium carbonate, and non-systemic include arginate, everything like that. So these are the in a brief manner. So just try to recollect this in the submitting. If you divide this entire topic, like as I mentioned the previously, that first of all definition, types, then and any clinical manifestations, then diagnostic models like investigations, then we have to write regarding the mode of treatment, how will aim of treatment, then followed by complications. If you remember in a systematic manner, then it will be easy for you to memorize at the time of examination. So thank you.